Hey, welcome to Health Equity Mondays, hosted by Jasmine Leonard
and Omari Richins. Here we'll talk about all things health equity, public health, and culture.
Let's do our part to move health equity forward and all that jazz.
Hey everyone, welcome to the August episode of Health Equity Mondays. You are joined by Omari and Jasmine, and today we're going to discuss how to prepare for fall with COVID-19, influenza, and RSV out there, as well as new research looking at who dies at higher rates of overdoses between men and women. Be sure to subscribe so you can keep up to date with Health Equity Mondays and all the conversation that me and Jasmine have around health equity, public health, and the intersection there. So please subscribe, share it with someone. Definitely share that equity in action question with someone and let them try to answer it, because sometimes it'll be difficult. And hopefully today I'll be stomping Jasmine.
You might. You very well might.
How you doing, Jasmine?
I'm doing well. I am living in the life of the last few weeks of school or not having school. So yeah, I'm doing well.
Well, that is good to hear. And how does it feel to be a two-time awardee, become an awardee for 40 under 40 for Black Health Connect, and then as well as the Health Equity now Health Equity awardee from Acclinate now included?
Yeah, I'm still living a high from that, so it's funny. I actually yesterday just put the awards up next to my other award from the previous 40 under 40, and I was like, oh, I feel special. So yeah, I'm still riding high.
Well, glad that you still feel special. That's good to hear.
How are you doing?
Yeah, I'm doing well. Doing well. Cannot complain. Cannot complain. Just putting in the work, putting in the hours, doing the things, trying to get back in the exercise routine, as well as just do more interviews for the Public Health Careers podcast. I guess by this time next week, you might know that I have my first intern. So that's huge for me. Like, someone's going to support and really see the vision and the mission of the work here. So that's been awesome, as well as I feel like it's going to be a learning opportunity for myself. So just looking forward to working with Brianna. Shout out to you. But yeah, more to come on that. But I'm doing well. Just trotting on. Like, I feel like I always say that, but just trotting forward.
All right. I'm happy to hear that. All right. So our first topic of the day is COVID-19, RSV, and what to know about for the fall.
Well, what's RSV, first of all?
Yes, it is respiratory syncytial virus. I was going to get to it.
Sorry.
But it's okay. I know that everyone needs to know. So let's first start with what we know. COVID-19, that's kind of the monster that we've known for the past 3 years. So hospitalizations have been trending upward since July, but experts are not expecting a huge spike and don't advise people to change your behavior. So continue living your life. Just know that hospitalizations are on the rise. And for context, the CDC has reported 8,000 new hospital admissions for the week ending in July 22nd. But at the same time last year, the number was more than 44,000. So we have seen a rise, but it's nowhere near what we saw last year. So we're doing better with pandemic control. And wastewater samples, because we now can't track cases by the states because the pandemic advisory has ended. So we're now tracking COVID cases through wastewater. So the wastewater samples show a general uptick in cases of COVID across the country, with the most impacted areas being the West, the Midwest, and the Northeast. However, again, when taking that into consideration and looking at this time last year, we're still relatively low. So what is the fall going to bring? We're not really sure yet. The experts do think that there might be an uptick in cases later in the fall. So we're thinking around October, early November. And to prevent this, the advice is to get vaccinated if you haven't yet, or to get boosted if you've already been vaccinated. Which leads me to the respiratory syncytial virus, RSV, because I'm sure by this time you've heard about a new RSV vaccine. So why should you care about RSV? RSV is a virus that typically impacts infants and can result in hospitalization. While it's more common in infants, it can impact immunocompromised people, elderly, and the young children. So that's what we saw last year. We saw a triple demic of COVID, influenza, and RSV. And now we thankfully have a vaccine against RSV. So who should get it? While everyone is recommended to get the annual flu vaccine and the COVID vaccine, not everyone is recommended as of yet to get the RSV vaccine. The CDC is recommending that infants less than 8 months old and infants 8 months to 19 months old, if they're at risk for severe illness, get vaccinated. And then there's also a newly approved vaccine for RSV for pregnant women. And there is a recommendation for people ages 60 and older to get immunized after consulting with their doctor. So you're probably like, cool, this is all great, but why should we care? What does this have to do with Health Equity Mondays? Well, we know that there are disparate rates of immunization among historically excluded communities. We know this very well from COVID, but the same could be said for childhood immunizations as well as flu. So the latest data is from 2017.
Wow.
So 6 years ago was the last time that the CDC looked at this data. And what it found was that in the American Indian Alaska Native population, children were 10% less likely to be fully immunized when compared to non-Hispanic white children. And then just 66.5% of Black children aged 19 to 35 months were fully immunized compared to 71.5% of white children. So if you're not like super familiar with all the vaccines that kids have to get, there's a vaccine schedule that the American Academy of Pediatrics puts out. And there are a series of vaccines that kids should get in order to be as healthy as possible. And when we say fully immunized, that means that kids have gotten all of the required vaccines and not the optional vaccines. So if you're ever interested in vaccines, I can talk a ton about it, especially childhood vaccines. But that's kind of the breakdown. When we look at flu vaccine, and this is specifically looking at the adult population, we have a little bit more recent data from 2021 to 2022 flu season, and that showed similar rates of disparities, with 42% of Black adults over age 18 receiving the flu vaccine compared to 53.9% of white adults. So it sounds all bad, but I'm going to show you some data that says that for COVID-19, it's actually not as bad. Well, so the Kaiser Family Foundation did a study of the race and ethnicity of people ages 5 years and older receiving a COVID-19 booster dose in the United States as of July 6, 2022. So last year, the Kaiser Family Foundation looked at this data, and what we see is that if we're looking at the booster dose, so that means that this is your second or your third COVID vaccine now, considering where we're at. The population actually seems to mimic about where the population size is for the respective racial groups. So looking at people who are fully vaccinated, 10% of the total population is Black that's vaccinated, 20% is Hispanic, 7% Asian, and then about 1% American Indian, Alaska Native. So when we look at this data, while there are some differences compared to the total population, it's actually not that bad. When we think about the total population of people who are vaccinated, 10% are Black, 20% Hispanic, 7% Asian, and then we have 56% white. And, you know, it's kind of around the population sizes when we look at the United States. So it's not alarming. It's definitely, it could be better, but I'm happy to see this because we all know that the COVID-19 vaccination efforts were huge, and there were so many people that came to help with that. So it does look like it did paid off. I think, there are good things to say about that. This is also, August is the National Immunization Awareness Month, so it felt apropos to bring this up during this month so that everyone knows what to do for the fall when we get there. And hopefully you feel comfortable speaking to your doctor or public health workers to let you know what's appropriate for you in terms of vaccination, or if you just have questions, because we know that there are a lot of questions still about vaccines, especially new ones when they come out. But hopefully, this little tidbit of information makes you feel a little bit more comfortable and you go out and get vaccinated.
Absolutely. We hope that we are the community leaders and people that you'll look up to get this kind of information and use it to take actions on. I was actually reading an article that COVID-19 has increased a lot globally. I think the cases have spiked like 80% from July to August. In this article that I have here that I will share, is that it says globally reported COVID-19 cases increased 80% over the past month compared to the previous month, according to the World Health Organization. That's nearly 1.5 million infections were reported from July 10th to August 6th. The UN Health Agency said in a weekly coronavirus report. And of course, we know, as Jasmine said, in the US now, we're not even tracking really cases by people reporting cases, because that has become very much non-existent, or very much less the case. Because if you think back to your life, if you've gotten COVID within the last couple of months, it is less likely that you've called the health agency and told them that you actually tested positive. So the numbers that we are getting are going to be skewed a lot. But I think it's just important, as Jasmine was saying, to just advocate for your community and just ensure that we are taking the steps to protect ourselves, especially with this new strain of COVID coming out. I think that I've seen in recommendations somewhere that people are saying wait until the new vaccine comes out later in this fall and
Yep.
then take that one. But just get a vaccine, because the modifications on this coronavirus strain isn't that different from previous strains, so vaccines are still going to be effective. If you'd like to wait to get a more effective vaccine, there's one that will be coming out in a couple of weeks. And especially as we go into colder months, definitely be sure to think about these things if you are immunocompromised or around older individuals.
Yes, and you can get the COVID vaccine and the flu vaccine at the same time. It's actually recommended. And like Omari said, the newest COVID vaccine should be out in a couple of weeks. And the recommendation is that you try and get it in September or October, before we go into the really cold months, which we know cause the increase in everything.
Yeah, so thanks for raising awareness on this, because I don't think we have been talking much about what has been going on with COVID-19. So appreciate you sharing that.
Yes.
Before we get into the next topic today, we're going to hop to promo break. Jasmine, what you got for us today?
My newsletter. It was a little bit late this month, but it did go out. So if you are wanting to know more about my journey to be a doctor and wanting to know what I'm doing and all the fun things, I have a free newsletter. It's Becoming Dr. Health Equity Jazz. You can find information linked below, and on all my socials. And that's it. I'm keeping it simple.
Be sure to check that out. The link will be below, as always. And for me today, just join my email blast. That's where I put out job opportunities. I share my thoughts on things, as well as their different podcasts, books, article recommendations that you can look at and just gain a deeper insight into what is going on in public health. And if you'd like to get updates on a new community that I'll be starting soon, be sure to join the email blast. It is below. You can go to thephmillennial.com/sign up, as well as the next public health happy hour, which I'm toying with changing the name to public health joy hour, but I feel like that kind of like goes towards public health Joey, Dr. Joey Washington. So I mightn't go that way, but regardless, public health happy hour will be happening when you listen to this, it'll probably be this week. So that will be Wednesday, the 30th of August at 5:30 p.m. Eastern. There's a link below to register. See you there.
Exciting.
Indeed it is. So moving on to the next topic that we're going to talk about today, which is researchers looked at who died at higher rates of overdose deaths between men and women using data from 2020 to 2021. And this article or paper was written in the Neuropsychopharmacology Journal, which is quite a mouthful of a name for a journal, but shout out to them for that. So some context on this. So as we all know, opioids have been surging for the last maybe decade plus now. And one of the things that I think about a lot is because I did a lot of opioid work while I was in my Master's of Public Health program, that the opioid crisis has still been going on while the pandemic has been going on, and it has gotten a lot less attention. And I think that it's an important topic to think about. We really do need the structures and systems in place to really take on opioids, but I will dig deeper into that at some other point in time in life, because I think that that's an important conversation to have. So in this study, they researched overdose deaths of men versus women across the lifespan. They used state-level analysis of epidemiological data on overdose mortality. So they looked at synthetic opioids, heroin, stimulant drugs such as methamphetamine and cocaine. The drugs were analyzed independently because they have different toxicity pathways. I think the article digs in a little deeper about that, but that's above my epidemiology pay grade. And I know you might be asking yourself as well, was the data controlled for other things? And yes, it was. So the researchers accounted for, or AKA controlled, for all things that you were thinking of. So men using drugs at higher rates than women, men's propensity to develop substance use disorders higher than women, and the level of misuse between men and women. And after looking at all this data, they still realize that men were and are dying from overdoses at higher rates than women in the US. The paper concluded that men are dying from overdoses at 2 to 3 times greater rates than women in the US between the years of 2020 and 2021. So this isn't the actual article. This is the NIH news release on the article, and we'll share both of these articles down below. The NIH is a summary of the larger article, and I'll share a little piece of the larger article just now. So we're going to be looking at the rates at which these drugs have killed women versus men. All the rates are going to be per 100,000 people or 100,000 of the population. And just to reiterate what they were saying, as I have highlighted here, for specific drugs and after controlling for sex-specific rate of drug misuse, the researchers found that the overall rates of drug overdose deaths by sex from 2020 to 2021 for synthetic opioids, example fentanyl, was 29 deaths for men compared to 11.1 for women. When they looked at heroin, it was 5.5 for men compared to 2.0 for women. When they looked at psychostimulants, example methamphetamines, it was 13.0 deaths per men compared to 5.6 for women. And when they looked at cocaine, 10.6 deaths for men compared to 4.2 for women. So I think this is really highlighting that there is some sort of disparity in what is happening, and it is something that we have to think about when we are thinking about public health interventions and policies that need to be enacted to prevent these types of issues. So the authors hypothesized that the combination of biological, behavioral, and other social and gender-related factors were the cause behind men dying at higher rates of overdoses than women. So when you think about biological, you think about something like men having a greater vulnerability to the toxicity of drugs than women, which is interesting in itself. And I feel like that you could dig into a lot more research around that. When they looked at the behavioral, so thinking about things like men may use these drugs in a riskier way than women, as well as social context, when we think about social determinants of health, as well as gender-related factors. And they went on in the article to talk about specific genes, and once again, a little bit above my pay grade. So why does this matter? As you all know, we are all health equitists listening to this, or public health professionals and public health professionals here. And a lot of the heart of this work that we do is understanding the issues and creating avenues to prevent and protect populations. And when I say that, I mean enacting policies, structures, and programs to ensure that we are addressing health outcomes equitably and making sure that it's equitably. And that's why we have to think about data when we are doing a lot of these practices. And I think being able to tailor the right solution to the right community and understanding that we have to look at issues in multi-layered ways, considering the biological, behavioral, gender, and often most important social factors are very, very cool. One thing that I wanted to highlight from the actual article, which I will pull up here in 1 second. So the thing that I wanted to mention here and what they noted in the paper around the limitation section was that, and quote, finally, the coding of gender identity in national mortality data is not currently routine, and these data sets do not provide information specifically for transgender or non-binary persons. This is an important issue because of the risk of SUDs or substance use disorder and overdose in transgender, non-binary, and or gender expansive communities. And I think this is a really good point that the authors mentioned, that even though we are looking at this data from a men versus women perspective, we're leaving out other communities because in this data, this national mortality data set, it does not ask the question about gender. And once again, we really need to think about how are we looking at data, how are we getting data so that we can enact the policies, the structures, and the programs to really address the needs of the community in the most equitable way. So highlighting my thoughts, this is very fascinating, and I think there's a lot more work that is going to be done to better understand this, whether that is understanding more of the biological, behavioral, gender, or social factors, and just understanding like why is this the case and how can we set up ways to prevent and protect populations around this. So a lot more to see here, but I just thought it was a really cool article that I want to highlight. And yeah.
Yeah, and it's really timely because if anyone knows me, you know that I watch a lot of television. So there's the new I guess, is it a documentary? No, because it's fictionalized. But it's they do draw from a lot of the truth around the OxyContin scandal and the Dr. Richard Sackler and Arthur Sackler, who like that family that essentially is responsible for the OxyContin use. And it's called Painkillers. It's on Netflix. Really good documentary. I watched it this weekend. Sorry, not documentary. It's dramatized. But the one thing that they did show was how insidious the opioid pandemic epidemic is, and kind of how it started from the doctors and the drug pharmacists and from the reps that were kind of pushing OxyContin in the ways that they were, without any real science behind it. So I think it's important that Omari and I are very big on giving you the science behind these things, because at the federal level, it doesn't always happen that way. And that's one of the things that this series highlighted, in kind of some of the failures that happened to get OxyContin on the streets as it was anyway. But very timely, given that I think more people are wanting to have conversations about opioids again, now that we are kind of in this new normal with COVID and letting more things rise to the top.
Absolutely. As well as there have been some large national litigation cases against some big pharmaceutical companies that have paid out monies. Because I know I work in a couple, well, all counties in North Carolina actually are getting some portion of money from this opioid settlement that happened for the next 18 years. And I believe there's a next litigation that is happening right now to try to address the opioid crisis. I've actually done my MPH thesis capstone project, I remember what you call it, on this. And if you want to read, I will link it below if you want to read more on it. And it was specific to Marion County, Florida, but it gave a good overview of what happened in the opioid crisis and what has happened. Granted, it's like 3-4 years old now, but not much has changed
Yeah.
from that.
Yeah, things are staying the same. So,
All right, y'all. So moving us along to the Equity in Action quiz of the month. This time I gotta ask Jasmine a question, a true or false question, and see if she gets it right. And at the end of the year, we'll have bragging rights, or someone will have to do something, depending on who wins or who loses. You have to figure that out. Let us know if you have any ideas. You can definitely comment below if you're watching it on YouTube, or reach out to us on Instagram. So the question this month. Well, are you ready, Jasmine?
whew, okay, I think I am. Let me. All right.
And it,
Oh, okay.
well, good to hear. Because in full transparency, I did this question yesterday, but I messed it up. So we had to redo the question a day after. Um, so here we go. The percent of clinical trials that is represented by Black participants is 4%. True or false?
The percent of clinical trials that is represented by Black people is 4%.
Correct. That is the question.
I know there's a disparity. That seems really low.
How low can you go?
I'm gonna say true.
It is false.
Is
Thank you for your
is it
try.
higher?
It is 5% actually, so
Okay.
just shy of that 4%. And I think I've seen in studies that it has gone from 16% all the way to like 2%, depending on what type of clinical trial study it has been. You're close though. You're close.
I know it's low, but
It it is very low. Okay, so when looking at this study that was done in 2021, from this article from the American Association of Medical Colleges, they say, quote, she wondered why and discovered that few patients had participated in the trial, which is typical. Black patients accounted for just 5% of clinical trial participants in the US, while white patients make up the vast majority. So there you have it, everyone. Even though it is not 4%, broadly speaking, it is 5%, which is still very low. It is disproportionate and it is a disparity.
yes, okay. You stumped me.
I'm glad to hear that. And just like to link it back to the episode and like the opioids and the substance use that has been going on. It's like when you're thinking about those biological factors and how men and women interact differently and how people of different racial backgrounds interact differently, it's important to have a balance in our clinical trials so that we're getting drugs that are actually efficacious for all communities. And I also wanted to highlight another article that I saw, which is kind of blew my mind as well. It said, and I will link it below. It's in the Lancet. And it says among 20,000 US-based trials with reported results, only 43% reported any race ethnicity data, which is wild to me. So around half of them are reporting race and ethnicity data out of all the data sets, which is very, very interesting.
Yeah, I actually did my undergrad senior thesis on this and looked at cardiovascular trials since the NIH guidance that went into effect in 1994 and then was reissued in, I think, like 2003. But they're supposed to be reporting race, but it's wild how many of them get through without ever mentioning anything about race. So it's definitely an issue. And even how they report race is just kind of across the board varies depending on who the researcher is and if they care about it at all. So,
Absolutely. And I think there's the other consideration that a lot of the times when they are collecting race, a lot of the race is categorized into other, and there isn't any defining definition of what other is. And I think we've spoken about what othering data does and how that is counter to getting towards equity and health equity. So there you have it, you all. If you guessed it was false that was 4%, let us know below. But I hope that you'll enjoy that. Ask your friend that question. dive deeper into the conversation and why this is the way it is. But thank you all so much for tuning in. Be sure to hit that subscribe button and share it with someone who gets some value from it.
All right. See you next month.
Peace, everyone.